So, good morning, everyone. This is Dr. Farooq. Today, we are going to welcome Dr. Said Chaudhary, who is an endocrinologist currently working at Cambridge University Hospital and in UK, and he's also an RCP educator and an OSCE examiner at Anglia Ruskin University. Today, our topic is endocrine emergencies in ED, which is very important, and we see them nearly every day. Before we start, Dr. Said, we are really excited and thank you for coming in and joining to this podcast today.
Thanks for having me.
Would you kindly tell us briefly your background, where you're coming from, and what you're doing, and how you achieved the position you're at the moment now for the audience? Thank you.
Yeah, of course. I'd love to share my story. Um, I think it's the story of a medical doctor working in Bangladesh in a peripheral city. I graduated from Bangla Medical College. Farooq Bhai.
Yes.
So I graduated from Bangla Medical College, and then I had my internship training in Sylhet Medical College.
Right.
So from Sylhet, so I wanted to go back to my hometown, home city. So I went there. I had my internship training, and during my training as a foundation doctor, I actually got really intrigued um, by the art of medicine, not the science part, the art.
The art. Okay.
Yeah, art of application of medicine. I was really interested about, you know, how we can apply cutting edge sciences for the consumers coming into a public
Hmm.
teaching hospital in Bangladesh. You know, hundreds and thousands of patients are really coming on the floor, and the doctors and nurses working there with a very high workload, they didn't have a chance to, you know,
Hmm.
explore the medical issues. Everyone was kind of busy how to accommodate them in a very small medical ward. So I did a lot of project and things, mostly management project, how to improve the service delivery from a very beginning of my medical career. So that what that did, I was actually, I was actually very focused on this improvement projects, and which introduced me with the very higher people. So, like the couple of professors in the Department of Medicine, they actually picked me up. So I got kind of groomed into medicine by them. So I was with them doing lots of activities, both science and arts, and then I actually grew a very strong interest in medicine. So I decided to do more training, do fellowship exam. I started uh, with my journey with the BCPS, Bangladesh College of Physician and Surgeon. But at some point of my postgraduate training, I realized that the medicine we are practicing, I mean, all great people were practicing medicine there, very brilliant doctors. But the cutting edge technology and the funding was really missing. I mean, it's no wonder, no surprise in the context of a country like Bangladesh. Everyone is struggling, in that belt. The whole Southeast Asia, African nations, they're all struggling because of the availability of funding and availability of cutting edge technology. Then I thought I cannot change this. So at that point, I realized, okay, the journey I started as a foundation doctor, I cannot continue it because I cannot change this. This is the main issue is funding and availability of cutting edge technologies. So then I thought, okay, I will move. I was at that time when I was a fresh graduate, I was actually reading a lot about Amartya Sen, Mr. Sen, who had a Nobel in economics. So I think he's a Nobel Peace Laureate. So he said at some point that people can change their lives and what they do simply by changing place.
Mm.
So if you change place, you will be overnight a different person. And
I think that's a very strong statement. I think it's a very important statement from
yeah,
Dr. Omotasan. Yeah.
yeah, exactly. So I was driven by that statement. I thought I would change the place then because I wanted to change it quickly. So I thought I'll change the place and my life will be changed overnight. And it changed overnight. So it's been around 10 years that I'm in NHS and it changed overnight. I came I think in September 2016 and I had my pay in a private teaching hospital in Bangladesh in August. And I had my pay in September from one of the NHS hospitals. And the contrast was it went up by probably tenfold. So that's how it changed overnight for me. So when I was in, sorry, I'm just dragging it too long about my
No,
personal
that's
history. So I just wanted to give the perspective, the thought that actually triggered the huge change in my career. And
yeah.
when I came in NHS, I actually thought I would do a career in neurology. I started doing a neurology job in a very, very big neurology center in NHS. But then the nature of work in neurology frustrated me. It's mainly long-standing neuro disabilities, and it's interesting when you do diagnostic workup. It's very exciting, very scientific, but then the long-term workup of it,
Mm.
it's still good, but I felt that it's not for me.
All right.
I found endocrine is very interesting, mainly because of nature of it. It's mainly clinic work. It's a clinic-based specialty in bigger teaching hospitals like ours, the Cambridge University Hospital. You have endocrine inpatients because Cambridge receive patients from across east of England. So we do have inpatient endocrines. But in most of the hospitals, a clinic-based specialty, and you it goes with your life and work balance very well. So that's what I wanted. Um, I I wanted to work for living, not wanted to live for work, if you know what I mean. So then I thought, okay, it's a good specialty. I'll start on it. The way I planned it, of course, I for a year or so I did a trust grid job. Then I moved into CMT. Then I did my higher specialty training. Um, and while I was doing this clinical training and clinical, you know, gaining all the clinical skills and experiences in the field, I was also doing bits and pieces to improve my teaching skills. So I did RCP accreditation courses with RCP London. I got engaged with universities like Anglia Ruskin universities. Previously, I worked for University of East Anglia. Currently, I also work for Cambridge University. So it's a long journey, but at the end of it, I thought it's an exciting journey with the triggering thought uh, from a quote by a Nobel laureate, and the way that it took turn, and I ended up where I am today. I thought it's a very
Thank
inspiring story.
Thank you, Dr. Said. I mean, it's very exciting. So we have, of course, a time limit. So I will
Mhm.
wrap up here because we know that you had a long journey from Bangladesh to United Kingdom,
That's
and then
Kingdom.
initially you interested in neurology, you changed to endocrine, and here you are working in Cambridge University as an endocrinologist. We have audiences who are mainly emergency medicine background or critical care
Yeah.
ITU. So we're gonna jump into the our clinical scenarios or questions. Okay.
Yep.
So for everyone to be more engaged, so I will start with common scenarios that we
Mhm.
day to day we have to see in real
Yeah.
life and in the exam as well. Okay.
Yeah.
So, Dr. Said, can you? So we're going to be have a brief, and we're going to be not going to go details into endocrinology today, just the emergency management aspect of
Yeah.
it. So we know we see DK, for example, DKA, diabetic
Yeah.
ketoacidosis, every day. How does this DKA patients normally present in ED? General idea.
You are the best person to, to tell us about that, Shobhaj Bhai. I think the when I was doing my early years of my medical registrar training, like as an ST3 in endocrine, I've seen my SHOs and other house officers look terrified when one of the ED colleagues walking to them and walking to the medical register or one of the medical team and saying, "We have got a DK in resus. Can you please come and see?" So the first thing, they come in a way that terrifies doctors.
Yeah.
They really can come very well. So what if we look very briefly, if we look into the pathogenesis, what triggers decay? Decay, I mean, in UK, you will see only very few patients coming with a new diagnosis of diabetes presenting with decay.
Right.
Most of the time, diabetes get picked up by primary care because of the meticulous screening programs. But and most of the times, because of the thanks to our electronic data system, most of the times when a patient is on the front door, you will know this patient.
Yeah.
Um, you know that they're under your endocrine team, the local endocrine team, and you will know that what sort of diabetes they have, what sort of past events happened to them. So they're known, but they can come unknown. New diagnosis of diabetes, type 1 diabetes can come very rarely, although most of the time it will be picked by primary care even before any catastrophic presentation. I mean, this is one of the successes of um, of how NHS works. Uh, Medical conditions get picked up even before a catastrophic presentation. So,
Yeah.
um, insulin deficiency is the key, and also ratio of glucagon and insulin is the key in pathogenesis. So they come most of the times. Decay would come to your resus, and most of the time decay would come. In many times, decay would come as a pre-alert. The ambulance crew actually pick them in the community. They will say very high glucose. Ambulance crew has good ketone meter nowadays, and they will say very high ketone. And when they come to ED research, the first thing you do a gas, and you see they are in diabetic ketoacidosis. I'm sure everyone is familiar with the diagnostic triad of diabetic ketoacidosis. We follow NICE and JBDS guideline And there's in 2023, JBS has changed a bit. There was a huge debate and meeting between British endocrinologists and American endocrinologists and European endocrinologists. And there was a bit of bargain in diagnostic criteria. And everyone got settled with a glucose of 11 millimole is a cutoff for DKA. So diabetes, you have to count everything, DKA. So diabetes, hyperglycemia, if it goes above 11, so it meets one of the criteria, and then ketoacidosis, ketones 3, and then acidosis. It used to be um, historically, it used to be both pH and bicarb. Now, it's not the fact anymore. I mean, if you get any one, either pH or bicarb, it actually meets the diagnostic criteria. So pH would be if it's less than 7.3, and bicarb criteria is now 15. It used to be a bit higher historically, but it's now 15. And bicarb is actually more of a important criterion than pH, because pH can be actually affected by presence of other inorganic acids. But you do emphasize bicarb more. Uh, So if you get your diagnostic criteria, the ED nurses or the first point of care, one of your house officers or registrar would pick it, and then they would start them on DKA protocol. So yes, presentation can be multi-system, and it can really involve water and electrolyte balances. It can really involve cardiovascular presentation. It can really involve autonomic functions and, of course, cognition. So you have to be very careful of systemic presentation. And last but not the least, you must find a trigger factor. If you are treating a DKA and you cannot see a readily visible trigger factor, you are missing something. So you have to ask yourself, what I'm missing.
Yeah. So just for the audience, I'm going to quickly summarize what you said. I think in UK setting, the idea is DK is actually is very uncommon to be newly diagnosed DK in emergency department because primary care already diagnosed these patients as a diabetes, type 1 diabetes. Most of the time we get pre-alert by the ambulance in ED that likely there's a query DKA coming in because they already have the BM sugar level high, and sometimes plus or minus, I don't see always the ketone meters are there, but they are suspecting DKA, unwell patient or very confused, agitated, vomiting, abdomen pain, a lot of like sounds like unwell, but they did query about DKA. So as soon as they arrive in ED, we do venous blood gas and ketones. That confirms the diagnosis. As Dr. Said says, is the diagnosis criteria is now sugar is more than 11, pH less than 7.3, ketone more than 3, and bicarb less than 50. And bicarb is more important than the sugar or pH. The other thing I would say, there are scenarios, Said. I mean, sometimes we see euglycemic DKA. Is it something
Yes.
you see as well?
Yes. So I was going to address that as next. So the pitfalls when you can miss a DKA, even in a very well-resourced setting like NHS, and it happened quite a few times. When DKA present with less prominent features, they can be missed.
Right.
Like when an elderly patient, diabetic, probably missed insulin or had a growing breathing infection, like an early stage of an UTI or pneumonia, they can very easily dip into DKA. And when they present more with the features of the trigger factor, for example, an infection or an MI.
Right.
Myocardial infarction can trigger decay. And when people present with myocardial infarction, you get busy with how to safeguard cardiovascular function
Hmm.
and how to kind of assess and stratify the further risk assessment and further management for MI. And you'll be very easily tricked into missing decay. So that's one bit. When presentation dominates the triggering factor, like sepsis or MI, rather than a biomedical derangement caused by decay. So it
Right.
can be missed at that point. And euglycemic decay. So with the advent of SGLT2 inhibitors, and those trials, I mean, very useful trials, multicentric, multinational, AMPA-REG trial, or Canvas trial, or DAPA-HF trial. Every trial proved superiority of SGLT2 inhibitors over other oral antidiabetic agents in type 2 diabetic patients. So there are two catches here. One, they're type 2 diabetic. And two, they're they 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 present with normal glucose and you miss decay because SGLT2 inhibitors has got this inherent issues with them, probably one of only few side effects, only few inconveniences that one can have on SGLT2. They're great drug. I love them. I prescribe them a lot. I advocate every type 2 diabetic should have an SGLT2 inhibitors on them because their efficacy is around 1 to 1.5% of hemoglobin A1C reduction, but their CBD risk factor modification is actually great. They improved life expectancy and reduced long-term mortality. So people are on SGLT inhibitors and they cause euglycemic decay. I advocate everyone coming to you with an acute illness in any setting, you should check ketone. Everyone on SGLT2 inhibitors, you should check ketone. That can cause euglycemic decay. Not very common, but you can also have euglycemic decay, particularly when you have type 2 diabetes and you're all on medications with infection and not even on SGLT2 inhibitors. MI, not even on SGLT2 inhibitors, and very early you can have. So any catastrophic event, acute intercurrent illness, we should actually check ketone, even blood glucose is normal.
Thank you. Said, I'm going to quickly rush you through because I have a couple of more questions coming
Yeah,
in.
yeah, of course. Sorry,
Uh, no,
I
that's
get
fine.
passionate
No,
talking
no,
about
no.
diabetic emergencies.
I know you're endocrinologist. I cannot
Yeah,
be.
stop me anywhere you want.
No, no, I cannot let be an endocrinologist today. You are going to be an ED endocrinologist, okay?
Yes,
So you're going to have
yes.
to stop you and ask you a lot of questions. So
Ask me anywhere.
if anyone in the audience have any question, just shout out or type in the chat box, okay? So what we're discussing about initially, we started with DKA diagnostic criteria, and then we talked about euglycemic decay, which is not uncommon in
Mm,
ED. And Said rightly mentioned that people who are on SGLT2 inhibitors, they can
mm,
have normal sugar but high ketone and decay picture. So always always check with the ketones with someone with SGLT2 inhibitors. So from there, let me in the real aspect, as many people would might be ask you. So in the textbooks, we see when the decay coming in, it's a protocol based treatment in UK. So
yeah.
the printed protocol, they come in the first hour, we take the
Mm,
blood gas VVG, we start normal saline 1 liter over 1 hour, okay, and then
correct.
the practice is after 1 hour you check another VVG and then you start fixed rate insulin, okay.
Mhm,
However, the practice sometimes uh, I've seen differently because people start insulin at the very start with the normal saline at the same time rather
mhm.
than wait for 1 hour. Can you briefly highlight that area?
Okay, fair enough. It's a very good question, Farooq Bhai, and we discussed this before. So, what's the catch here? If you have a DKA, the first thing you do, you open a cannula. You open a line with a cannula, preferably a large bore, and you start pushing in fluid. Because if you look into pathogenesis, there's of course hyperglycemia, and hyperglycemia driven, glucose driven diuresis. Glucose is a very potent diuretic, and glucose driven water loss causes loss of electrolyte and shift of electrolytes. So it causes absolute deficit in potassium because it takes a lot of potassium out through diuresis with sodium. And it causes water loss. People come to you with hemoconcentration, very concentrated blood. If you check their osmolality, it will be very high. So what you want to correct first? You want to make sure that when the insulin hit the board, you should not have any, at least you should start correcting the hemoconcentration. So the first thing you open, you put a cannula in and you start IV fluid. So that's action one. And action two is insulin. Now, you should not wait for fixed rate insulin to be started on after starting IV fluid. But the catch is, if you are having delay in inserting a cannula or inserting fluid, you should not think, okay, let's do some insulin. Let's give us bolus. Let's do a strong shot of insulin because there is no insulin deficit in type 1 and want to correction. No, that can be paradoxical. So from that point of view, you should always start with IV fluid because you do not want to worsen the shift of electrolytes by giving insulin and not giving any fluid.
And
So
and
if
also,
they yeah, sorry.
no, sorry. I think as a good as also at the beginning, we do have the potassium on VVG. So we know
Yes,
the potassium.
yes,
If let's say, as you said, yes, we can start insulin at the same time. However, and as their volume depleted and probably potassium depleted as well.
yes,
The risk is if we start insulin, people think, oh, I'm gonna draw the potassium lower into dangerous level.
yeah,
Let's say initial VVG potassium, if the potassium shows less than 3.3, that's the
yeah.
cutoff. Would you be scared to start insulin? What would you do in that scenario?
Yes, yes. So there are only few indications when actually um, um, insulin can wait until you insert a cannula and start fluid. Hypokalemia, severe hypokalemia, potassium level less than 3.3 or even 3 is one of those indications when insulin can wait, even in decay. You should always start with fluid. You should actually replace potassium with IV fluid with high concentration. And then this is one of the indications when you should not, as any consultant, you don't talk to the medical team, you actually talk to HDU.
Yep.
This is one of the indications.
Those patients likely speak to ITU, HDU. Yes.
Yes. So severity marker is a very important thing to catch severity marker at the initial assessment. And everyone should know, everyone working in ED or an acute medical take should know what are the severity markers in a DKA patient. I will not go through those because of time. I'll leave it to you. If you ask me a specific question, I can go through that.
Thank you. Thank you. Now, I think the audience is here. I'm just going to check whether they have any. If anyone has any question in between, just let us know. Okay. We're going through the DKA. We're not going to go the detailed protocol of DKA because we already know in the textbooks. So
Yeah,
anyone coming with DKA is diagnosed very early on in ED based
mhm,
on ketones, VVG, which shows pH, bicarb, and sugar. And it's already flagged by the ambulance crew before they
yeah,
arrive. And as soon as they are here, we have the cannula, we start the IV fluid, and the potassium is the potassium in BVG is okay. We can start initiate the fixed rate insulin at the same time, and we carry on hourly BVG monitoring, okay, and monitoring the insulin fixed rate. However, there are some scenarios when we can involve ITU, which is if the potassium is very low to start with, maybe it's less than 3.3, which
yeah.
needs a potassium replacement to start with. Those are very potassium depleted patients. Um, my question is why ITU? Is it something we can give a potassium replacement in normal saline and reassess, or is it something
So
I
yeah, it is mainly for yeah, of course you can start fluid, but you have to if it is severe hypokalemia, you may need to give higher concentration of potassium. So you need probably will need a better line than just a peripheral cannula.
Right, right. And
I can quickly show you if I can share my screen. Actually, in a table,
right.
what you want to do. Uh,
All right.
do you see my screen?
There is a one question before you share the screen.
Yeah.
Uh, Someone is asking, oh, Abdul, Dr. Hamid. Hamid is asking, what should be the guide? Uh, they say, what should be the insulin infusion rate and what should be the guide, the shift from 0.1 to 0.05 uh, units per kilo?
Okay. So I think essentially the question about insulin adjustment.
Right.
So the dose for insulin is fixed rate 0.1 unit per kg per hour. The only time you reduce insulin is when you have started someone in decay and they started responding and they reach a point when you have corrected hyperglycemia and blood glucose has come down below 14 millimole per liter. At that point, you do two things. So this is one of the pitfalls, even in an NHS setting, where decay management can go wrong. When you correct hyperglycemia, but still there is ketoacidosis, or still acidosis is being corrected, we don't do this adjustment very often. Number one adjustment, reduce insulin dose to cut it by half that you are giving now, zero
Yeah.
point 0.1 to 0.05. And second, you will start at 10% dextrose at 125 mils per hour rate. And these are all done to avoid hypoglycemia.
Excellent. I think this is a very important question. Thanks, Dr. Ahmed.
Very
So
important question,
the,
yes.
the summary is if when you're correcting the blood sugar, if it is falls less than 14, then we have to either half the insulin in fixed rate insulin, so 0.1 to 0.05 units per kilo. At the same time, we start 10% dextrose is 125 mils per hour. And these are the two changes needs to happen when the glucose falls below 14. Thank you. And at the same time, I think if the glucose still goes in the opposite direction, let's say after 1 hour giving somebody's sugar it was 15, it's become 16 or 18. So if the sugar goes in the opposite direction on the same fixed rate insulin, you can actually increase the dose. Dr. Said?
Yes.
Yeah.
Yes, of course. Sorry, yes. So when you increase the dose, that's another pitfall where DKA treatment go wrong. Because the way NHS work, you have a dedicated nurse and resource.
Right.
And they are very well trained to go with the protocol. But in the protocol, within the protocol, there are small prints. They will say, at this point, ask the senior doctor. And when you come as a doctor, what you do? That's what you need to know. Because the protocol say, call the doctor. The
Right.
protocol doesn't say what the doctor should do when they come. It is the discretion of the senior doctor. They come, they assess the scenario, and they can go beyond protocol. Protocol are for the common people, like the heterogeneous group of doctors to
Mm.
ensure the uniformity. And then when you are in charge, you have to you have to customize the protocol. So the question is, when you increase insulin,
Mm.
you have to know what you are achieving with DKA protocol. You are achieving the broad objective is resolution of DKA. But DKA will take at least 6 hours, can take up to 24 hours, ideally. So you cannot wait till 6 to 24 hours and say, okay, I have achieved or not achieved protocol. Then I have to do something or not do something. You have to review every hour and see if you are en route to achieve the protocol.
Mm,
And that's where you have to know the the rate of resolution.
right.
When somebody is an IV insulin, IV fluid, potassium infusion, and you want to see their ketone is coming down by 0.5 per hour, you want to see their glucose is coming down by 3 millimole per hour, you want to see their bicurve is coming up by 3 per hour.
That's
If you are not achieving this rate,
mm,
probably in 2 successive hours, I generally give 2 successive hours, then you increase the insulin. Then you must think, okay, I'm not giving enough insulin. They need enough insulin because we have to remember when decay get triggered by an acute illness, for example, sepsis or MI or other condition, the actual insulin efficacy is worse because any infection, any intercurrent illness like MI will increase peripheral resistance to insulin as well.
right.
So
For
yeah, sorry.
sorry, I'm just gonna quickly summarize again because
Yeah,
I think we have 1 second. We don't have much time.
no
Uh, just to summarize, you say very important things to the rate of resolution, okay?
Yeah,
For the audience, because they might not or not everybody is aware about it. There are three things you mentioned to make sure you do the hourly VVG and ketones, and when the rate of resolution by meaning you expect sugar to come down 3 millimole per hour,
yeah,
bicarb 3 per hour, and ketone you said 0.5,
yes. So
not 0.5.
bicarb should go up.
Bicarb should go up.
You want to get out of the acidosis. So you want
Exactly.
to see more and more bicarb.
All right. For example, a 70-kilo man, you start at 7 units an hour. Okay.
Yeah.
However, you don't achieve this rate of increasing bicarb or falling down of glucose
Hmm.
and ketones. In a 1 hour, the sugar comes from, let's say, 15, it become 18. Ketone is still high, is getting actually higher. What rate would you change on that
So
particular
if it is roughly, I would increase a unit more.
N unit?
If there
Okay.
are seven, I'll take it to 8.
Yes, yes. So for the audience, the rate can be up or down. Again, depends on the rate of resolution, okay, and the sugar level. As we already discussed about, less than 14, where you actually have the insulin rate that you're giving, and at the same time, if it is not achieving the level you want in every hour in terms of ketone, glucose, and bicarbonate, do double check, and you may have to increase the rate. Okay, so that's really key important thing. Um, of course, we discuss about potassium. Let's say, so potassium 3.3 to 5.5, which is a normal range. So if it is more than 5.5, you don't need to add potassium. Is that right?
Yeah, that's correct.
Yeah. And in between 3.3 to 5.5, how much potassium would you like to add? Is it you giving normal saline?
Yeah,
Do you want to use another line for potassium?
yeah,
Same line.
yeah. So um,
Yeah.
between 5.5 and 3.5, I think you give 40 millimole KCl. But as I always said, do hourly assessment, see if your potassium is within the range, within the target range. If it is not coming up, you can always go out of adjust the decay protocol. Decay protocol is not the last thing. Being a doctor in charge of the treatment, you can actually go out if you find justifiable reasons. It's best to be within the protocol, but if it is needed, you can actually go.
So if someone is, let's say, 3.5, you want to give 40 millimole potassium in 1 liter of normal saline over how many hours?
So ideally it take 4 to 6 hours, but you can still, again, you can actually tweak the timing depending on how the potassium is responding in next gas.
I see.
Yeah.
Right. You can start in 4 hours, but you can actually make it a bit faster if
Yes.
you feel like. So how fast you can actually give this 40 millimole if needed?
I think with the peripheral cannula, you cannot you are actually tired. You cannot go very fast. If you want to go, you need a bigger cannula, you need to go more central, and
Mm,
you need to go more high dependence unit
I
if you
see.
want to go faster.
That's fine. Yeah, I mean, to be honest, I think, as you say, we are right. We need to be safe and check the hourly potassium. So, if you give 20 millimole, like roughly it's 20 millimole in 2 hours, 40 millimoles in 4 hours, so 10 millimoles an hour. That's our goal, and you keep checking it. And if it is need further faster potassium, then we have to uh, speak to IT or HDU.
Yes. So that for the extra bit of potassium, but you should go
Right.
with the protocol. As
Go.
the protocol says, 2 hours fluid with KCl, you just go by that. But for
Right.
extra bit of potassium, the duration and the amount, it can be actually determined based on how they're responding to decay protocol.
Yeah. Let's say the ED research, the treatment is really going very well. A couple of hours later, and the nurse come to us saying, "Hey, doctor, the potassium is now less than 3. Maybe it's less. Potassium is still is 2, and sugar is now coming down. Okay, so it's probably less than 11. So it's getting much better. They're asking whether should we stop the insulin or not. What would be the answer?
So stopping IV insulin, two things, two options. If it is stoppable, you can either switch to a variable rate, but it's still IV, or you can switch to regular subcut insulin.
Right.
Or if they were not on insulin pre-DKA and they were diagnosed, you can actually switch to their regular oral medication as well.
Yeah. Depends. Also, it depends. I think
Depends.
there depends on the DKA protocol. There's protocol
Yes,
based, and
exactly. So,
mm,
so when to do what? So as a I mean, non-endocrinology, you have to be very brave to switch someone from DKA protocol to oral medication. It has to be an endocrinologist.
no, that's fine. I don't think I'm not going to go that discussion because we don't do that in ED. We don't
Yes.
do it.
I,
Actually,
I think people get moved from ED
mm,
within 6 hours of starting decay protocol. So you don't actually see the end bit of it.
no,
You start them on fixed protocol, you actually fix the biomedical derangement, and then patient get moved from ED. So in answer to your primary question, you should look at the resolution criteria.
yeah,
So
yeah,
what are the resolution criteria? First, you should achieve normoglycemia.
mm-hmm,
JBD is actually not emphasizing on glucose anymore like it used to. They're emphasizing more on um, uh, acid-base status and ketones.
yeah,
So if your ketone is less than 0.6, it's
mm,
very important. Very often you will see patient is not acidotic more, and you will see ketone is tiny bit higher than 0.6, and people ignore. It's very important that ketone comes down below 0.6
right,
and your acidosis is completely corrected.
right,
Bicarb is 18 or pH is 7.3 or more.
mm,
So when you achieve those two criteria, mainly acidosis criteria, pH or bicarb, and um, I emphasize more on bicarb than pH.
yeah,
I trust bicarb more than pH, and also a ketone. Then you actually switch them. You stop fixed rate. Now, if your patient is eating and drinking and they are alert, well, eating and drinking, no cognitive deficit, and you trust them that you will give subcut insulin and they will be eating enough, they will not be dipping into hypoglycemia,
mm,
you can switch them to subcut insulin.
mm, right,
But if they're not eating and drinking well, their intake is unreliable, you still keep them on IV insulin, but
right.
on a variable rate,
The variable rate, not the fixed one. Okay.
not the fixed one.
Or we can switch to the sliding scale. Is it?
So the variable rate, this is so sliding scale is a misnomer for
Mhm.
variable rate.
I see. I see.
So we
So,
call it variable rate IV insulin infusion, VRIII.
oh, what I'm trying to by slangs, I was thinking like, is it a subcut or is it misnomer thing? So
No, sliding scale is variable rate IV insulin infusion because
the
it
same.
slides
Okay,
depending on the glucose level. They
exactly.
give you various ranges.
of sugar.
The the DKA protocol chart will give you as ranges of glucose. So every hour, your nurse will check their glucose, and if it is within certain range, they will give 2 unit. If it is go higher, three. They will adjust insulin,
That
slide the insulin
that
doses.
is still
That's why
IV.
it is called sliding dose.
Yeah. So that's still
Still
IV,
IV, yes,
not subcutaneous.
not subcutaneous.
Thank you.
For switching into subcutaneous, you have to be absolutely certain that you push subcutaneous dose of insulin, and you rely them that they will, yes, they will eat and drink. Otherwise, they will dip into hypo.
Right. There are two questions on the screen, and to quickly read through the question. So first question is from Dr. Ibrahim. So the question is, DKA secondary to STEMI, do we start DKA treatment first in ED, or do we send the patient to cath lab immediately? Which one first?
That's a very, very good question. I think so. I can give you an example of what I was called to see as an endocrine on call from ED research. It was just last week.
Hmm.
So a gentleman came with neck fash. So he came with
Neck,
very,
I think just to clarify, people by neck
oh, sorry,
necrotizing
apologies.
fasciitis.
Necrotizing fasciitis. Sorry, apologies. Is the terminology in NHS. So someone came with very erythematous sole and right half of the face, and very uh, thankfully, one of the ED registered, as they're very good in picking up necrotizing fasciitis, they actually picked it. And everyone came on board, ENT, plastics, and the patient was taken into theater within minutes of arriving into any resource. But as they were moving into theater, we were opening channel and everything, and I was there as an endocrine on call, probably within first 5 minutes, I was in any resource. And by the time I was there, it was all started actually. The IV, there was a line in, fluid in, and also when they were talking to me, I have asked them, "Can you start on fixed rate?" And
Right.
I'm coming and saying, so yeah, you do it all at the same time.
Same time,
There's
same time.
minute means
Yeah. And
minutes.
again, it can be necrotizing fasciitis, or even if it is MI going to cath lab, but you
Yeah,
still
yeah.
not
So any
immediately.
tissue damage,
Exactly.
be it in your heart, be it in your skeletal muscle, anywhere,
And
any tissue damage.
so whatever the patient goes, you carry on with the DKA protocol. You start the treatment, and then you move to the theater or the cath lab.
Yeah, yeah.
Did it. Thank you.
You, yeah, you start everything.
Everything before you move.
Because moving to cath lab will take time, ideally.
Yeah.
In our setting, like in our hospital, we do our PCIs in Papworth. So Papworth is a different hospital,
Oh,
different trust. We have an underground tunnel that we use to move
I know. I've
patients.
been through the tunnel in Cambridge, so
Yeah,
I'll come back to the tunnel. This is a long, scary tunnel.
yeah,
Cold.
scary tunnel.
Anyway, so let's move on to the next question from Dr. Ahmed. It says, any point on fluid resource of DKA patient with heart failure and reduced ejection fraction? So what
Ah,
the,
yes, yes, very
this tricky
important.
situation?
So this is one of the other pitfalls. DK, after establishing DK protocol, there are only few pitfalls. One is that what we talked earlier, that we don't adjust insulin doses because we don't care about the resolution rate. And
Mm,
the other is this volume,
well,
fluid status,
right.
pregnancy, extreme of age, heart failure, CKD. You adjust fluid based on whether or not you are overloading, and how you monitor overloading. You look fluid overloading, like central and peripheral.
Mm,
So you actually keep a very careful eye on, um, of course, EF. You can do a focus echo, bedside echo, and see what's the feeling, and you can actually adjust your volume status. Yes, of course. In answer to your primary question, you definitely do reduce volume of IV fluid and the rate of IV fluid depending on their fluid status.
so obviously, if someone is acute pulmonary edema, heart failure, we wouldn't give a bolus of normal saline in that patient?
No, no,
No.
very careful, yes.
That's a very important question, guys. I mean, thanks, Dr. Ahmed, for bringing it up. If someone is really volume overloaded, low ejection fraction,
Yeah.
pregnancy, heart failure, shortness of breath, you sense the overload. Obviously, you monitor the volume clinically, and also
Mm,
maybe you check the urine output
yeah.
and X-ray, echo, everything. So if someone is volume overloaded, don't give.
I'm so happy, Farooq, you mentioned urine output. So
Yeah,
this is the other pitfall that we often ignore.
right.
You have to make sure that your patient is producing 0.5 mil per kg of their body weight every hour to be feeling safe that you are hydrating enough.
Yeah,
So
absolutely.
until you go to that point, just crack on with hydration. 0.5 mil per kg per hour.
And ideally, because the fluid management is a bit tricky in DKA, I think we should be a bit of proactive on whether thinking of putting a catheter or not. So, if you put a
Yeah, yeah, but it's
catheter,
in the protocol. You
it is
have to
in the
put in a
protocol.
catheter.
Yes, it is in the
Mm,
protocol. So we have to put the urinary
yeah,
catheter just to make sure this
yeah.
this urine output is
Mhm,
appropriate for the fluid. So
yeah.
this is
I,
another way to check the fluid balance.
I just wanted to ask, is everyone, they must be familiar with the international guidelines, but is everyone familiar with the JBDS protocol, or do we use it at our working setting?
Right,
Is anyone interested to comment on that?
right. Guys, open questions. Do you have any protocol that you follow in your hospital? JBDS means Joint British Diabetic Society.
And I apologize again for using all these
No. So yeah.
terms.
So whether it's a JBDS or any protocol, do you guys just shout out? Do you guys use or just type in? Do you guys use any protocol in your institution for DKA management? Yes or no?
Not actually one, but we usually follows the text still. Like in my institute, we are following the ICU protocol published by the Indian Society of Critical Care Medicine, and
Mm.
quite a lot of points are similar to what the management has been discussed today. I was just raising the points which I did not uh, uh, get clearly from those guidelines, like the question about the heart failure. It's not clearly mentioned there, but I have come to know
Mm.
about the guideline today. Maybe I will visit it recently.
So Hamed,
Yeah, so it's a very convenient guideline, JBDS. You have a flow chart in JBDS website that you can access. It's really, really very helpful.
and I think Hamed, did you mention that you're following an did you mention that you're following an Indian guideline from India?
It's not actually their own guideline. They have picked it up from different societies or different guidelines. Actually, it is the IC protocol book.
I think, I mean, after this meeting today, I might have to email everyone about the guideline that Saeed is speaking about. So, Saeed, can you send us that JBDS guideline up to date one?
Yeah, yeah, sure. I'll forward it to you.
Yeah.
Um, I was,
Because I feel Bangladesh is immense helpful to have a protocol in hand to manage all the DK patients. And if you guys don't struggle to find the standardized protocol in Bangladesh, those patients are not improving very quickly, I'm telling you. So we need to
yeah,
have a protocol in hand in any ED, any hospital that that has anyone from, I can see Parvez Bhai and Marwan. Anyone shout out from United Hospital? What protocol do you use? Parvez Bhai or Marwan, are you there?
Assalamu alaikum, Farooq bhai. Yes, we are here.
No, no, please
uh,
tell us what protocol or
yeah.
any protocol for DKA.
Oh, I've been following your conversations, and most of your guidelines are in line with the ones that we follow in our ED at this moment. And definitely, we stick to the protocols of NHS and JBDS, what Dr. Saeed mentioned. And yeah, it looks so far we are using the standardized guidelines for the time being.
And do we keep a printed out pages? Like, do you have printout folder or anything in the department?
Yes, yes, we have it. We have posters being put up on the walls and maybe on the boards as well, just to help us with the guidelines from time to time during the rush hours.
Yeah.
So we get to go through them again and again, because there are so many numbers that you tend to forget and mess up between each of them. You know, point so much so per kg per hour per minute
Yeah.
and so on per 24 hours. So yeah, those guidelines do definitely do help during the crunch hours, and it's better to have a guideline than have no guideline and go beat about the bush.
And I'm sure that Dr. Pavs, you mentioning about the JBDS guideline or any other guideline you're talking about.
Yes, yes, yes. Most similar to the JBDS and NHS guidelines,
Yeah.
and yeah, it's more in line with those systems, and also we use these for assessing the complications and
Hmm.
special age groups like elderly, heart failure, children, and all
Yeah.
that.
No, thank you. Thank you.
Yeah.
So that, I mean, we are very close to 1 hour. We can extend a bit more if you guys are still staying here. We have, I think we have Dr. Said. I'm sure that I'm going to bring Dr. Said another session because we're not going to covering everything today. Okay.
Yeah, yeah,
It's
of course. And
possible. And
yeah,
if
and
possible,
no
I
one can
don't.
stop me when I start talking. So.
No, and because
Sorry,
we are very ED focused, so we have to have a very quick, short, and specific questions. And there are
I know for a way.
a couple of candidates are on this FRChem and MRChem candidate. They know this bit of
Mm.
focused answers. So one other thing, how a patient ended up having raised ICP with decay protocol, and have you seen them? How do they manage? How you get involved? Tell me.
Mm. To be honest, I mean, getting raised ICPs, cerebral edema,
Yeah.
as a decay complication, um, is now very rare in NHS. It has gone very rare, because of thanks to the protocol,
Yeah.
because of the protocol. It kind of ensured uniformity in treatment. So it's mainly how quickly you were correcting hypovolemia and how quickly you were facilitating the shift of electrolytes across the cells. So, for example, if you correct with not with crystalloids, we don't see this anymore in NHS, but it used to be in the past, and I think across other areas in the world, not using crystalloids, isotonic saline at the beginning.
Hmm.
If you start with glucose,
Oh, okay.
you are actually increasing the risk of having cerebral edema. If you are rather not addressing hypernatremia, so if at any point electrolyte balance doesn't equilibrate and you start having hypernatremia, and then you have to adjust your fluid and start giving half strength normal saline 0.45% to still maintain the volume status, but also not going over the par with sodium balance.
I think it's a very key. You said you also want to see the sodium level because
Yes. Yeah.
people,
Yeah. You do using every hour.
yeah,
Sorry again. Urea and electrolytes every hour.
urinary everywhere. So definitely it's a risk of giving too much sodium or too much fluid and ending up getting decay. So as I say, it's very rare in UK settings, but it's probably not going to be rare in Bangladesh setting because
No. No.
less monitoring. So you may have we giving fluid, and then we don't
Mm.
watch the output or the sodium level and
Mm.
develop cerebral edema. And again, I believe that with raised ICP patient can be very confused, so
Exactly.
this GCS is not 15,
Exactly.
agitated. So if any decay patient suddenly becomes neurologically unwell,
Exactly.
agitated, confused, just think about cerebral edema,
Mm.
and then obviously you go. That is the point again. You involve the ITU, HDU team. Okay, you
Yes.
start the hypertonic saline, everything. So, and any particular other changes in the protocol of DK you
So
carry on the same?
very important, Farooq Bhai. Again, a very important question. So this sodium balance is of more particular issue in management of HHS,
Right.
hyperglycemic, hyperosmolar state.
Hmm.
The the previous nomenclature is gone now. So it happens more to that. And if you look into JBDS criteria for resolution, diagnosis and resolution of HHS, you will see it's not only biomedical, it's not only osmolality, not only urine output, and there is inclusion of cognitive status as well.
In HHS.
In
Oh,
HHS, you have to look for cognitive improvement until you declare HHS is resolved.
I see.
Cognitive improvement. So it is very helpful, very important not to just play with the urea and electrolytes number and
Yeah.
the ketone and acid base status.
Yes.
You have to go to the patient and actually talk to them intermittently and find out if they're cognitively improving as well or deteriorating. So
Right.
any cognitive decline, low GCS or development of seizure actually indicate cerebral edema.
Thank you. I mean, obviously, a couple of audience already thanking you for all these clinical tips and everything,
Oh,
which
thank you.
no, welcome, welcome. So, which and since you mentioned HHS, I'm really keen to ask a bit more question on HHS
Yeah,
because
of course.
HHS, I think, as we know, is probably more life-threatening than DKA.
Yes.
Why is
Yes.
that? Why HSS is more life-threatening than DK? I think many people probably don't know this. Just we need to know that this HSS is more dangerous. Why is that?
So, in answer to your question, why is probably because the fluid loss here is profound.
Right.
HSS patient can lose up to 20 liters of fluid.
And
Can
it's
you
very,
imagine?
very slow process, like gradual process, not like an acute presentation like DKA.
No.
Diagnosis of HSS may be delayed. Is that what you're trying to say?
Yes. Because for losing 20 liters
20
from your
liters.
body,
Wow.
up to 20 liters can be lost.
Hmm.
So for losing 20 liters, you don't lose 20 liters in few hours or day, which means when an HSS patient is under you in resus or in A&E, the process is started probably days earlier.
I
Their
see.
body was trying to compensate and everything, and they were still going on,
Yeah.
standing on their feet.
Right.
They will only crumble when things have gone so very wrong.
Right. Right.
So the HHS patient in hospital in A&E means they have been unwell for a long time. And also, like in DK, we know that insulin deficit is the problem. We give insulin, they're sorted. In HHS, there is no absolute insulin deficiency, though. You still have some insulin in your body, which inhibit lipolysis, which is why you don't get ketone.
Right.
That means the counter-regulatory hormones played bigger role here. Glucagon versus insulin ratio is the critical in development of HHS. And that causes huge metabolic derangement. The degree of metabolic derangement in HHS is much worse than the degree of metabolic derangement in DKA. And the single player in DKA is insulin deficiency that drives it all. But in HHS, there are multiple players. This is why it is more critical. Prognosis is worse. Even in NHS, mortality is around 20%.
Right. So HHS you said is a multifactorial than just insulin.
Yes.
Like more volume depletions and electrolyte.
More and more profuse volume depletion, more complex electrolyte derangements. Although acid base and acid base and anaerobic glycosylation is not that bad. Acid base is
So
kind of okay.
hypothetically, let's say if we don't treat any of this, if someone is DKA, doesn't get any treatment, how do they die? Do they die out of electrolyte imbalance and cardiac arrhythmia? Well, how do they die normally?
So in DKA, they will very quickly die because of cardiac arrhythmia. Potassium will go low and low because of absolute deficit. In HHS, risk of um, risk of cerebral edema is higher. They will die of cerebral edema and of course also cardiac death due to electrolyte imbalances.
Ambulance. Okay, okay. So it is good to know why they're dying and what is the main reason we need to fix. So there are a couple of requests. So somebody's asking to have another session on thyroid or other part of endocrines that we
Yeah,
need
yeah, of course. I'd love to share a few of the complex thyroid cases.
Yeah. And I think because we normally say 1 hour, I think we got and this is surprising. I thought I'm gonna cover the whole endocrine in 1 hour.
No, no.
Completely
Because
not
decay is so much more.
yeah. So we'll definitely set 1 hour. So it says Dr. Pavel says viscosity is higher in HHS. Is it?
It is because you lose so much of
Yeah,
fluid.
true.
Everything get very thicker.
True.
And this is why there's a profound risk of thrombosis in HHS. And this is absolutely critical. If you are dealing with someone with HHS, this is absolutely critical. I know we don't practice that in Bangladesh, but we practice it like a religion in NHS. Hospitalized patient, prophylactic chemoprophylaxis against thromboembolism is very important. You give low molecular weight heparin, any hospitalized patient, you do that, but you do that more religiously if if you are treating HHS. Their risk of thromboembolism is very high. Very significant number of patients in HHS actually die because of catastrophic PE, because they develop thromboembolism very quickly.
So PE, MI, stroke, all these things can happen more in HHS than DKA. Yeah, right. That is something I need to look into as well. I mean, keep in mind that if acute MI, the HHS can come as an acute MI or a stroke. Okay, so
Yeah,
those are
yeah.
things because of
They can be trigger. They can be both trigger and the outcome.
Right, right. So let's we're gonna have to gradually wrap up soon, but I can't stop myself asking you one more question. So
Sure.
because we started on HHS, so I think the difference in management in DK and HHS. So in HHS, you don't start insulin right away. You start the fluid first.
True. So fluid is the mainstay of HHS management because this is the biggest issue here. And you replace fluid, you keep replacing aggressive fluid. And very often, most of the electrolyte imbalances, most of the biomedical issues get actually corrected by only fluid replacement.
Right.
But if you are getting more and more ketone, which means you actually have, in addition to all the biochemical derangement of HCs, you actually also have a bit of insulin deficiency. So I think in that case, you can start half dose of fixed rate insulin
So 0.05 unit per kilo.
instead of
That's
0.1.
after you've resuscitated with fluid.
Yes, of course, fluid first.
If the ketone is still high after, you said, is it 1 liter or a couple of liters? Depends on the ketones, isn't it?
Yeah, I think what I follow until I get urine output, and urine output is absolutely important. If you keep hydrating and getting no urine output, you'll be in trouble. So once I see some urine output, I then brace myself and look into everything. I
Right.
start looking into everything, checking ketone and things, and
Some
kind of
urine,
try and
definitely.
determine whether they need a tiny bit of insulin or not. But in
Yeah,
most
yeah.
of the cases,
So,
it will win with fluid only.
so we don't need to jump into insulin in HHS.
No.
Wait for the fluid,
Yeah.
replacement,
Exactly.
bit of urine output, and also how, let's say, we need serum osmolality to diagnose HHS or not.
Sorry, Farugwe?
I said, do we need serum osmolality to diagnose HHS? Because let's say someone,
Yeah, I mean, the diagnostic criteria is based on serum osmolality.
yeah,
So you can calculate or you can do a real-time serum osmolality. Of course, that also calculated in lab. So yes. So I'll give a very short answer, yes.
yes, yes. So
Mm.
I think in ED, let's say someone can, because we still don't have urea. In BVG, we can have sodium, glucose. We don't have the urea there. We don't have the osmolality there. How would you calculate this osmolality in ED?
You have sodium and potassium, right? And you have urea in ED as well. ED POC does urea. In Edinburgh, it does that. In Cambridge, we do urea in ED, yes.
In BVG, I don't think in Broomfield we
No,
have
not in VBG. We do POC urea.
point of care urea.
Yeah, there's like a point of care machine that can calculate urea, creatinine, and that can.
We don't have that. I don't.
Yeah, I think only few hospitals have it.
So my catch is, let's say I'm clinically suspecting HHS. Someone's sugar is high and not a DKA picture. Okay, but do we? Of course, we start the fluid. Hopefully, we'll get the urea and osmolality from the lab within an hour. Is there any other tricks that we can use, or just have to wait for the diagnosis?
I mean, when you have very high blood glucose, when your blood glucose is very high, and if you have a profoundly hypovolemic patient, you should always consider about treating HHS.
Yeah,
Treat as if you were treating HHS
right.
until you get everything.
Exactly. And that's the thing. I think, yeah, Dr. Parvis says they have the point of care Chem 8 in United Hospital, which is great. I wish we have more point of care in all UPEDs. I don't think we don't have everything as a point of care yet.
Is it why most of the Bangladesh hospital can't have it? Is it because of money? I mean, is it very expensive?
So it's not really
Or
expensive.
people are not quite aware about?
I think many people probably not aware, okay? Because in point of care, I think even in United, I think they have a tropin D dimer. Professor White, do you have tropin D dimer? I'm just asking directly to Professor. Yes, he said yes. So
Yes, we do. We do. We have Chem8, we have Tropi, we have the ABG, BG, whatever you need. We have this point of care facilities started from the last couple of years,
do you have
and
D dimer?
it's we don't have data, but we'll get it soon, I guess.
And by Chem 8 means he means urea and electrolyte, is it?
Yes, we have urea, electrolyte, hemoglobin. We have the uh, calcium as well, creatinine. These are all those
I
parameters.
mean,
We have the electrolytes as
right.
well.
Nice.
So
So
we have all these.
is it a different machine? Is it not an ABG machine, or you're talking about a different
It's
machine?
it's a different machine. It's a handheld machine actually. We
Ah,
use cartridges and a handheld machine.
right, right. No, that's
I wanted to ask Dr. Parvez, do what EPR you use, like what electronic system, data system you use for operation?
Uh, I'm not aware of that. I'm sorry, but it's a machine that we use here. That we insert a cartridge and take the sample,
Hmm.
maybe a couple of drops of blood,
Okay,
and
fair enough.
yeah, use the cartridge, and then I can send you some pictures of some of the samples that we have, and I can share it with you. Maybe you can figure out what systems we are using. I'm not actually aware of those systems that they use.
No problem. That's fine.
yeah,
Thank
Dr.
you.
Parvez, please do send us some pictures because again,
Sure.
the other question is how reliable they are. I mean, because in UK, I don't think everybody has this urea and electrolytes as a point of care in ED because the question is probably not standardized or they probably don't trust more than the lab. But as you
Yes, we do send a secondary sample to the lab, nevertheless.
Confirm.
just to verify, and or at least we do two samples, one ABG, one VBG, or one ABG, one Chem8. So we compare between the two. If two are okay with giving the same values, chances are most likely that it's accurate. But if there is discrepancy between the two, then we discard both of them, and then we send to the labs to make this confirmatory results.
Right. Nice. And you also do the bedside troponin, isn't it?
Yes, yes, we do that. We do that as well.
Thank you. So it's good to know. Um, right. I think we can carry on, but we need to wrap up. It's over an hour already,
Yeah,
and I will make sure we will have more. Like it was really really important. Discussion is very very important for all the ED, IT, or any doctor actually in general, whoever managing DKA or any endocrine emergencies
yeah,
is
of course.
very important. Thanks, Dr. Said. We're lucky to have you. Okay.
No problem at all, Farooq bhai. Really happy to interact with you and your disciple. It's great, actually, very interactive. We were talking about HHS, and I just want to conclude this with one pitfall, which probably will give greater insight in managing HHS. So um, the only situation where you use a full dose of IV insulin in HHS is the entity when you can have mixed HHS and DKA.
That is very important.
Yeah.
That means
There will be patient coming with sky high hyperglycemia, profound volume loss, and also acidotic and ketones high. So you treat them as mixed DKA.
wow, wow.
Makes HHSDK with
We
0.1.
we will catch you in our next session. Okay.
No
So
problem.
let's summarize today. Again, I think we're really, really it was really helpful, very, very insightful, thoughtful, and everybody's appreciating all the inputs, which sometimes is difficult to find in a good textbook to cover all this. Okay.
No
Prob
problem at all. I'm happy that it was useful.
yes. And Dr. Said, I'm sorry that I stopped you many times
No problem at
because
all. Please stop me whenever you need.
because I know that any perspective is a bit of more any point of view. So, however, it is it is a very very productive session today. Today, I think we briefly talked about DKA, bit of pitfalls. I would ask everyone to, if you're missing any question that comes, any question, if you thought of any other question, just email me. You have my emails, and so the next session will be more prepared to answer your questions. So I would rather ask everyone to thought about any endocrine questions or exam related or in real life. I'm more focused on real life, which also covers the exam question as well. So all these questions, all these situations can come in MRChem or FRChem SBA as a question. And right. Thanks, Parviz Bhai. I think he shared some of the VVG or yeah, Chem8 scenarios on that chat box. But thank you, Parviz Bhai. And so let's conclude this session today. Any final comments from your side? Because we're gonna come back. We need to come. We want to make sure that you come back next time to discussion.
Farooq bhai, I can't hear you well. You were
Oh,
breaking. I didn't hear last 10 seconds.
I see. I'm sorry. Can you hear me now?
Yes.
Okay. Any last comments? We're going to conclude now, Said. Thank you so much. Okay. And
No problem.
and I just any last word from your end? We have to definitely want to bring you in. I'll speak to you about the next session at some point. You need to come back to us, and then any last comments from your end?
No, thank you. Thanks, everyone. It was a pleasure. Been a pleasure. And look forward to meet you again.
Thank you so much. Said, I'm going to conclude the meeting now. Okay.
Thank you.